Hello, my name is Dr. Corey Vilson. Thank you for joining us today as we talk about why addiction is a brain disease and why it's important. Is addiction a disease or is it not a disease? Does it matter? In today's episode, we sit down with a group of top experts to dive into the definition of addiction as a primary chronic disease of brain reward, motivation, memory, and related circuitry. With over 20 million Americans suffering from substance use disorder each year and over 42,000 opioid overdose deaths in 2016 alone, it's never been more important or urgent that addiction be understood and addressed using the most accurate and up-to-date science. The way we conceptualize addiction matters as it is critical to treatment and recovery efforts. Today we're joined by Dr. Bertha Madras, a professor of psychobiology at Harvard Medical School, serving at McLean Hospital with a cross appointment at Massachusetts General Hospital. Dr. Madras is the former Deputy Director for Demand Reduction in the White House Office of National Drug Control Policy. Dr. Madras was appointed as one of 6 members of the President's Commission on Combating Drug Addiction and the Opioid Crisis. Patty McCarthy-Metcalf is the Executive Director of Faces and Voices of Recovery. She served as Deputy Director of the Center for Social Innovation at SAMHSA's Bringing Recovery Supports to Scale Technical Assistance Center strategy. Ms. McCarthy-Metcalf served for a decade as the Director of Friends of Recovery Vermont and is a woman in long-term recovery. Dr. Indra Sidambi is the Vice President of New Jersey Society of Addiction Medicine. Dr. Sidambi is the founder and medical director of the Center for Network Therapy, New Jersey's first state-licensed outpatient detoxification program for alcohol, anesthetics, benzodiazepines, and opiates. Dr. John Kelly is the Elizabeth R. Spallin Associate Professor of Psychiatry at Harvard Medical School, the first endowed professorship in addiction medicine at Harvard. At Mass General, Dr. Kelly serves as the Director of the Recovery Research Institute, the Program Director of Addiction Recovery Management Service, and the Associate Director of the Center for Addiction Medicine. Welcome to all of you. To begin, Patty, can you please tell us what is meant when we talk about disease?
Absolutely. According to the definition in the Merriam-Webster Dictionary, a disease is an impairment of the normal state of the living animal or plant body or one of its parts that interrupts or modifies the performance of vital functions. It is typically manifested by distinguishing signs and symptoms and as a response to environmental factors, to specific infective agents, to inherent defects of the organism, or to a combination of these factors.
Great. And Indra, can you please tell us what is meant when we talk about addiction?
Addiction is now recognized as a disease. Relative to a couple of decades ago, it was considered as a behavioral problem. What is a disease? Addiction is a disease because we have a causative factors. The biological reason, which is the genetic cause, and the environmental factors. Being born and brought up in a chaotic family and not have a parental supervision, and while the parents are using drugs and or alcohol, and being with the peer who are using drugs and not having those appropriate school guidance, and the academic performance is really poor. These are the environmental factors, along with, most important, exposure to trauma at a extremely early ages of development. What I mean by that is the physical abuse and the sexual abuse that someone faces in the community that adds to this illness. And having said that, those are the causative factors. And there are, because I started off saying that addiction is a disease, it has the other signs and symptoms of diseases, such as when someone uses illicit drugs and or the mind-altering substances in a problematic manner, it leads to symptoms like tolerance, withdrawal symptoms. When they attempt to stop, they're unable to stop in spite of having negative consequences that they face due to the use of drugs and or alcohol. So that kind of makes addiction a disease which is totally out of control. And
Sure.
added to that, there is a chronic brain changes one can see.
And John, can you tell us about the disease model of addiction?
Well, I think, just zooming out a little bit and thinking about, why are we even having this conversation about addiction and focusing on it as a disease? And I think, when we zoom out and look at the historical context of how we address these endemic problems in our society, and there's been a kind of a tension between, is it a criminal problem or is it a medical problem? Is it a public health issue, or is it one that's really people should be punished out of? And so there is this tension throughout history of how best to treat it and address it as a society. And I think nowadays there's been a swing towards a greater public health approach and a medical approach. And I think that's why there's been a relative emphasis on addressing addiction as a disease, calling it a disease. Now, I don't think we have to necessarily use the term disease. I think the synonyms of illness or disorder are also adequate, but I think more the general point is that we are treating it as a public health and medical issue as opposed to a criminal justice issue. And there are different types of disease models. There are many been explicated or detailed throughout history, but as we've learned more about the nature of addiction, what it is, how it affects the central nervous system, how it affects the brain, we understand more clearly that that is the organ that is principally affected, that relates to the impaired control over use despite harmful consequences. It's the inability to regulate, even despite very severe consequences, that creates the conundrum that we see and the devastation that we see. People lose the braking system in their brain, or it becomes impaired such that they can't accurately predict how much or how often they are going to use when they engage with the drug.
Bertha, can you tell us about the disease model of addiction, perhaps in terms, should we be comparing it to other chronic addictions, other chronic illnesses?
Well, for many people, addiction is a chronic illness. And why do we say that? It's because people can have craving and relapses throughout the entire course of their lives. That is one of the main reasons why we call it a chronic illness. In terms of biology, we could also attribute it to the fact that we can observe brain changes, that some of which disappear over time and some of which do not disappear over time. And it is critically important to recognize that a chronic disease is one in which the behavior, the aberrant biology can persist over the course of a lifetime. And I think that's the principal reason why we are concerned about its chronicity and the fact that we always call people recovering as opposed to recovered or purely cured.
And Bertha, what changes in the brain are characteristic of addiction?
The changes in the brain are at multiple levels. They are changes in terms of the primary targets of drugs, the so-called receptors or transporters. There are changes within the cell of these targets. There are changes within the circuits of the brain. There are changes within the anatomy of the brain, and there are changes within the function of the brain. Every single layer of brain function that we are aware of, we can identify changes depending on the drugs. There's also toxic changes. For example, in alcoholism, you can see shrinkage of gray matter over time with severe alcoholism. With a number of other drugs that are frankly very toxic, such as methamphetamine, you can see changes in loss of nerve cells or nerve endings. And with regard to opioids, for example, opioid overdoses, because they cause a lack of oxygen going to the brain and lack of blood entering the brain, both of them have consequences, so that we're beginning to see more and more people with severe memory loss because the nerve cells that are most susceptible to oxygen deprivation, in fact, are damaged. So the changes are not only in terms of adaptation to these abnormal signals that drugs produce, but also the changes are due to, in some cases, frank toxicity, damage or destruction of individual nerve cells or certain regions of the brain. The stages of addiction are very simple. The initial encounter with a drug gives rise to positive reinforcement. This positive reinforcement can lead to a person escalating their dose and beginning to binge to an extent where they're intoxicated by the drug. And if they do this frequently enough, they can have withdrawal. And if they have withdrawal, it automatically tells us that the brain has adapted to the drug. Because in the withdrawal state, that person no longer feels normal. They don't feel very well. They're dysphoric. They have a negative affect. And so what compels them to go back to the drug? What compels them is to remove the negative state and also to reinstitute that feeling of euphoria that the drug produces. And then, after a while, the brain continues to adapt until you reach a point at which you begin to crave, you begin to anticipate the reward, and by that time, there becomes a mindset in which some natural rewards become of lesser significance than the reward produced by the drug itself and the relief from the negative state.
So Bertha's given us a background on the neurobiological perspective on addiction. Let's talk a little bit about the biopsychosocial perspective of addiction. And similar to other illnesses, it's not just one factor that causes the onset of addiction, but rather it can be a combination of risk and protective processes and their interaction that can work to influence addiction. John, can you give us an overview regarding the biological factors that could increase risk for addiction?
Yeah, well, as Indra already kind of alluded to, kind of the complexity of psychiatric illness. And in substance use disorder is a psychiatric illness. So it's, by definition, a complex illness. But it's a function of multiple factors converging to produce the phenotype or the expression. And included in that, of course, is the genotype. So the genes, we know, roughly confer about half the risk for addiction. That in and of itself, it doesn't mean it's genetically determined, but it's genetically influenced. It relies on the intersection or interaction with the environment, including exposure to the substance. And genes, the way that genes confer risk is through two main processes. One is through metabolism, and the other is through reward. So when people are initially exposed to a substance, if they have the right genetic makeup, they may feel a much more profound experience on initial exposure, which, as Bertha mentioned, leads them to repetition because it makes them feel so good. And so some people are protected just by virtue of the fact genetically they don't have that positive response. They may even have an aversive response to that initial exposure, which protects certain people. And this is why we know that in the population, when you look at people who are exposed, only a certain proportion of those exposed will actually meet criteria for a substance use disorder. So there's some of the ways that, for example, biological factors, genetics, for example, can confer risk, but it's a complex illness that relies on the interaction, as I mentioned, with these other factors developmentally.
And Bertha, what else can you tell us about biological factors that might increase the risk for onset of addiction?
Well, I think that parents especially, physicians especially, should think about some of the most important risk factors that can promote addiction. Number one is the environment at home. If there is acrimony at home, if a child is neglected, if they're allowed unlimited access to social networking, if nobody seems to care about homework or who their friends are, if they are psychologically, emotionally, physically, or sexually abused, all of these are very critical risk factors. The second risk factor is the biology of the adolescent brain. we have to recognize that the adolescent brain is not fully formed. It undergoes remarkable and very critical changes in at least 4 different ways. One is that the brain starts to prune away connections that are unnecessary. The second is that some of the functions of the brain shift into different areas. For example, an adolescent shown an emotional face is going to react with the emotional part of their brain that drives risk-seeking and other factors. But if you give the same emotional scenario to an adult, they react with the frontal cortex, the part of the brain that stops impulses, that's responsible for impulse control and judgment. So the brain is changing in terms of function, it's changing in terms of structure, and it's changing in terms of social development. Adolescence is a most critical time, and what we've learned over the past decades is that the earlier a young person begins to use drugs during adolescence, the far more likely they are to become addictive. And that includes marijuana, cocaine, methamphetamine, heroin, prescription opioids, alcohol, benzodiazepines, nicotine. All of these have been shown to confer a high risk if introduced into that most tender period when the adolescent brain is developing.
Indra, can you give us an overview of psychological factors that can increase the risk for onset of addiction?
Just to add how Dr. Medeiros really talked about the brain, the prefrontal cortex. Interestingly enough, when you see an adult who is abusing drugs and or alcohol, they tend to exhibit behaviors of a child. The growth is not, when you put that age and look at the behaviors, they don't equate. They look as an adult, but they're acting like a child. That's because the decision-making capacity of the brain is lacking. And the poor decisions that they make is really causing a lot of problems. And they keep saying to themselves, because they have a cognitive distortion now, they keep saying to themselves that all the problems that they face are due to other issues in life or blame it on other people, and never look at what really caused the problem, which is the addiction. And so the psychological issue is when they have any abuse in the early age, and almost most of them with the co-occurring diseases now, with depression and anxiety, PTSD, which is the post-traumatic stress disorder, this only increases the sufferings of this addiction. And it's not easy for them because the neuroplasticity that occurs in the brain really opens the way for learning. There's a learned processes, and they're starting to crave for drugs, and they cannot stop using. So it's a vicious cycle.
Patty, can you describe to us types of social and environmental influences that may have a relationship to addiction?
Sure. The good news is that we know an awful lot about addiction, but we also know that many people can and do recover from alcohol and other drug addiction. And so the factors that have been discussed, psychological and biological factors, have an influence in not only developing an addiction, but also can be protective factors that can be put into place in people's lives to help them recover successfully. And so when we look at risk and protective factors, it's very similar to the work that the prevention field does. When we look at what are the pieces in a person's life that could be improved or help them build their recovery capital. So the protective factors such as they have strong relationships with family members or mentors in their life. If that wasn't in place growing up, we can put that in place in their recovery. We can help them. The other thing is that the pieces of protective factors that may not have been in place for young people growing up, we can look at those as areas where we need to improve and build build assets such like recovery capital, putting into place a foundation. So the same, having a safe and stable place to live. that's a risk factor if someone did not have that. But in recovery, we put those things into place. Environmental factors and regulatory factors, such as laws and access to treatment and services, are all part of what society could do and how we put those environmental factors into place and really reduce the barriers for people in their recovery to overcome alcohol and other drug addiction.
I think, and if I just add to that, I think sometimes it can be confusion in that, if we call addiction a disease of the brain, then how could friends, jobs, and housing affect recovery? There's not a clear connection between brain neurobiology and these kind of more macro-level factors. But what we do know from actually studies that have been done looking at brain biology is that actually social networks and social connections change the brain. They alter, upregulate. It would appear the dopamine D2 receptor, for example, that are downregulated with chronic exposure to drugs. So actually having a rich social network, having housing, having a job which builds recovery capital and social status, which is also correlated with dopamine receptors, actually are associated with recovery status, because higher densities of dopamine D2 receptors are protective against relapse, and social networks and jobs and houses increase those neurobiological factors. So there's a connection there that was not immediately obvious when we think about recovery.
So we've defined disease and addiction. John, can you tell us what does constitute then a substance use disorder?
Well, it's interesting because I think we tend to think about addiction and substance use disorder as the same thing. Now, in some cases it is. Actually, on the severe end of the spectrum of substance use disorder, we do see addiction. That's what addiction is. It's really the severe end of the spectrum of substance use disorder. But somebody, when we use our current diagnostic criteria of anywhere from 2 to 11 symptoms, for example, using the DSM-5 criteria, somebody with 2 or 3 symptoms actually may not actually meet criteria for what we would consider to be addiction. Nevertheless, they are exhibiting a pattern of behavior that is associated with hazards and harms, which can get them into trouble, health harms as well as other kinds of legal problems, because they're engaging with an intoxicating substance. We call this hazardous and harmful use. So I think we have to be careful. And I think this is where sometimes some of the confusion comes in between, wait a minute, somebody's using a substance heavily, but are they really addicted? Are they addicted to the substance? And I think this is where we can make the distinction between addiction, which is the severe end of the spectrum of substance use disorder, and the lower end of the spectrum, which may or may not lead to addiction. And this is where I think we can, again, needs to be clear. Sometimes it does. Sometimes it is a kind of a prodrome for addiction. In other words, they're on the path to addiction. But even if they weren't, there's still a necessity to intervene because of toxicity and intoxication-related harms. Because those 3 pathways through which substances cause harm, it's addiction, intoxication, and toxicity. They're independent but related harms.
So regarding substance use disorder, can you tell us what's changed in the DSM-5 from the DSM-4?
Well, we used to have two subclassifications under the heading of substance use disorder in DSM-4. It was substance dependence and substance abuse. And you had the more classic, what we would think about as addiction, which was dependence. So there were 7 symptoms. You had to meet 3 or more to receive a diagnosis of dependence or addiction. And you had the abuse criteria, which were 4 criteria. It wasn't really a syndrome because you only had to meet 1 or more. And there was a problem with the reliability of that particular construct, because it was really captured the consequences of addiction as opposed to an independent disorder per se. So that was dropped, and they were clumped together in DSM-5 because the abuse criteria was shown to be correlated with the dependence syndrome itself, the addiction syndrome itself. In other words, as you got more addicted to a substance, you had more of these consequences, which were the abuse criteria, more legal problems, more social problems, etc. which in the original explication of addiction back in the 1970s by Griffith Edwards, he talked about this biaxial phenomenon where you had addiction on one axis and then the consequences or related problems on the other axis, which became abuse and dependence. And they were clustered together in DSM-5 to create this single category where we have anywhere from 2 to 11. So obviously that creates a great deal of heterogeneity, right? There's a lot of variability. If you can have anywhere from 2 to 11, that creates a lot of different types of people who can meet criteria. And this is why we have those sub-specifiers of mild, moderate, and severe. I don't think we use those enough or think about them enough. We might just talk about a substance use disorder, but somebody with 2 symptoms who meets criteria for a mild substance use disorder, it's someone probably very different than somebody who's meeting 9 or 10 criteria. Now, they may be on the path, they may not be, but I think we need to be clear about what kind of substance use, to what level of severity that we're addressing.
And I also think we should intervene at all levels
Yeah.
for that reason,
Yeah.
because we don't have a crystal ball that can predict who will progress towards a full-blown addiction and who will not. But in the meanwhile, even mild use can lead to consequences.
And I would add to that, saying that the treatment should be tailored to the individual needs. So if somebody presents with substance abuse issues, it's not appropriate to send them into an inpatient short-term and or a long-term rehabilitation. It can be dealt in an outpatient level of care, including the withdrawal symptoms, as an outpatient detoxification. So that kind of reduces the stigma, and it gives the person who's addicting substances to accept treatment much more comfortably.
Readily, yeah.
And so do you believe there is a difference then between substance use disorder and addiction? And do you think that that competes with the DSM definition in any way? Or?
No, it is, as John explained clearly, is the severity of the substance use disorder, gets to be an addiction. But if you really look at people who are addicted to substances, it is not one pathway. It can be advertent addiction. So due to chronic pain and or anxiety, people might get addicted to substances. Or it can be just trying to be accepted in the community, meaning the peer pressure. And so they start using drugs. And they're too stressed out to relieve tension, they start abusing drugs. It'll be a self-medication model, and then co-occurring diseases. Or it can be recreational, fun, just to experiment on drugs. So as I said, just addiction is a big umbrella. We need to really specify what it is, and as we spoke about mild, moderate, and severe, the severity is very important.
So we've reviewed some of the defining properties about disease, addiction, and substance use disorder. Why is the definition of addiction as a brain disease important? Let's just start with talking about some of the advantages of using the brain disease model. John, can you please speak in terms of stigma or discrimination?
Yeah. Well, it's interesting because I think, when you think about all psychiatric illnesses, arguably, you could classify as diseases. I mean, they meet the definition. And here's the question, when you think about, well, is addiction a disease? Well, the question for me is, does it meet the definition of disease, which we read out at the beginning? And I would say, yes, it definitely meets the definition of a disease. So I don't think, at least I can't see an argument there, and it's either it does meet the definition or it doesn't. I think the question has to do with relative emphasis and utility. And a long time ago, Eldon Jelinek, some of the people may know the Jelinek curve. It's a very famous curve. Very he was somebody working in the alcohol field. He produced a book back in 1960 called The Disease Concept of Alcoholism. And what was very interesting in that book, he actually he talks about this definition of alcoholism as a disease, of course, as the title would suggest. But he says that when you talk about alcoholism, the disease of alcoholism, he says, there are many definitions of the word definition in the dictionary, more definitions of the word definition in the dictionary than there are of disease. Okay, and he says that you can't really argue about the definition of disease unless it goes against the rules of the defining process. But you can argue about its utility. So this notion of utility, I think, is very important when we think about how much relative emphasis should be placed on addiction as a disease or a medical illness or disorder. And I think the reason is, coming back to the original, is stigma. There's much more stigma, and this has been shown in multiple surveys, when the people are asked about mental illness or addiction. People have much more stigmatizing attitudes towards people with addiction. I think that part of that reason is because it involves an initial choice to imbibe a substance. And it's that, as we've talked about, it's the biology, the genetics of the person which determines what happens next, whether they repeat the behavior, find it rewarding and reinforcing, or stress relieving, negatively reinforcing, which leads to repetition, and that repetition on exposure changes the brain.
John, just to add to that, genetics, if you look at any chronic illnesses, let's compare now hypertension to addiction, right? Both have genetic predisposition, and then you can see that 30 to 40% of people who have genetic predisposition do develop these illnesses. There is no difference in that. And then if you look at the choices that you mentioned, the choice of using drugs or alcohol among people who are getting addicted, the same choice does happen in terms of chronic illness like hypertension, because there the choices are slightly different. The food that they choose to eat, with too salty ones and with high level of fat and lipid content. But then there are also the activities, trying to lead a sedentary lifestyle, refusing to have healthy life choices. So there is a choice there too, so it doesn't differ much. What is the difference there? Really, like, it's a chronic disease, be it addiction and or hypertension. And so when you see the relapse rates, 30% of people are not able to keep up with the lifestyle changes with hypertension. 40%, less than 40% patients who suffer from hypertension really adhere to the medication. So what is the difference? The difference is because how we started treating addiction. I think the very first thing that happened in the history, looking back, addiction was not treated by doctors, not the medical professionals who jumped on this. First of all, it was treated in the community, and then with the Alcoholics Anonymous came along, and then we jumped in. It's pretty much a young field of medicine, right? So I think that is where we are having the struggle. Otherwise, we wouldn't have even talked about, is this a disease or not? It would have been one among any other chronic illnesses. So I think that's most important to focus on.
Bertha, what are the advantages of using the brain disease model in terms of medicalization?
Well, I think there are a number of advantages. Clearly, in terms of developing improved medications to treat addiction, one has to know what the drug targets are. One has to understand how the drugs change the brain. And if you look at brain imaging, for example, there's certain types of brain imaging that actually can be predictive of whether or not a person will stay in treatment for a long period of time or not. So the medicalization goes hand in hand with the concept of what the drugs do to the brain, as well as what types of treatments we be seeking to assist people. We know, for example, with opioid use disorder, that untreated with medications, people relapse at extremely high rates. With, if they have medications, they will be retained in treatment for longer periods of time. The obvious conclusion is that the medications are telling you that this is a biological phenomenon. Withdrawal is telling you that it's a biological phenomenon. So in terms of understanding what happens to the brain, in terms of using that information to develop medications, in terms of using that information to promote prevention, in terms of using that information to help medicalize and bring the concept of addiction into mainstream medical education, in terms of using it to develop public health policies as an approach to treating and to addressing the problems of addiction, there are many, many reasons for using the disease model.
we talking.
Yes, please, go ahead.
No, Dr. Madras really captured everything about how to treat addiction. And the real problem in the clinical field that I face is that medication-assisted treatment has been pushed back. We have found quite a number of medication to help people who are struggling with this disease. But then, where is the problem? When we use an agonist versus a partial agonist-antagonist towards the antagonist medication, group of medication, there is a pushback. People, even in our field of medicine, are preferring one over the other. In spite of patients doing well on certain kind of, maybe on an agonist, they would say, condemn the patient, saying that you need to come off of that and should go on an antagonist because you're substituting one drug for the other. And that is a misconception. And it's really heartbreaking to watch patients not able to go back to work. As John mentioned earlier, being active in the society is one of the phases of treatment, right? But if someone is sober for, say, an year period of time, engaging in treatment, and then the employee-assisted program is condemning them for being on certain medication, and they're asking them to switch over while they are keeping sober, that puts them to go back and use. So Dr. Madras did explain beautifully that using medication is important, and we have quite a number of medication out there, and we are not doing justice as treatment providers. And to add on to that, we have the 12-step group, kind of pushing patients not to be on medication. Recently, my patient did mention about something called MARA in Pennsylvania, which is the medication-assisted recovery anonymous groups. So the AA is accepting more and more in these kind of form patients being on medication. That's promising.
Bertha, in terms of research, what can you tell us about the benefits of using a brain disease model?
Well, in terms of research, it's clear that research has led to the brain disease model because biological research, first in animals and then in humans, showed that every single drug of abuse, of addiction, of substance use disorders promotes changes in the brain. Some of these changes are simply adaptive to try to dampen excess signals created by the drugs, but others are toxic, as I said earlier. And the most important thing that we want to understand with research is not only how do drugs change the brain in order to develop improved medications, but also to shape treatment modalities. As I said, there's very good information now that shows that with imaging, you can see a giant disconnect between the frontal cortex that is critical for impulse control and for judgment being dampened after excess and lengthy use of drugs. And it's more and more disconnected from the impulse part of the brain, the emotional part of the brain, the amygdala, the extended amygdala, and so on. And by looking at these brain images, we can begin to understand and decipher what circuits are involved in addiction. And if we can have an objective way of showing that the circuits are reversed through treatment and so on, we can, again, help to educate the public on the hazards of initiating use, help to educate the medical profession on the need to incorporate this into medical education and to engage their patients in this critical topic, and help the public understand that in fact these drugs can promote changes that are consistent with the disease state and have a measure of mercy towards people during this phase of use and recovery, so that they can have a compassionate approach to their treatment and to their perception.
And I think we've got our work cut out for us, in terms of the comments that have been made, just because we've got so much education to do. So it's great that we're doing programs like this. Hopefully people will watch it and understand more about the true nature of what we've learned, because this is only relatively new information. And as Indra said, we've got providers in the medical profession, in the addiction medicine world, who are disagreeing with actually what the science is saying. So it's a matter of actually getting the data out, translating the data, getting it into clinical practice guidelines and in medical communities and in conferences to be able to really emphasize that this actually can save lives and it can lead to better quality of life as well as saving lives.
Patty, can you speak in terms of public policy and funding? How would a brain disease model be advantageous?
Right, absolutely. And having identified addiction as a brain disease has helped us significantly work on public policy and move towards a more comprehensive approach to addiction. So understanding that we need prevention, we need early intervention, treatment, and recovery to fully address addiction. And the brain disease model helps to advance that in public policy. So when talking to funders, policymakers, we know that that full continuum needs to be supported so we can help people recover. We also have made great strides with the Mental Health Equity and Addiction Parity Act, which requires insurers to cover addiction and mental health at the same level that it does for other medical conditions. So by eliminating the stigma of addiction, we'll find more people who will access treatment and engage in treatment and recovery programs and reach out, because it is a medical condition, a disease that is impacting millions of families across the country. And by addressing it on a public policy level as a disease, it really helps to eliminate some of those barriers for people to reach out and seek treatment.
Bertha, you've worked in public policy. How do you think this brain disease model comes into play there?
I think the brain disease model at this point is widely accepted by policymakers. It's accepted by the United Nations Office on Drugs and Crime. It's accepted by the World Health Organization. It's accepted in many sectors of our political force in the United States. It's not as accepted in some other parts of the world, I must say, where addiction is treated quite differently, and I've seen a number of countries that have been quite surprising in their approaches. But it is, and I think one of the most important things is educating policymakers, educating governments at the federal, state, and local levels, educating judges in drug courts, some of whom deny a person being on medications-assisted treatment in order to remain out of prison. There are a number of areas where there has to be a vast increased understanding in this model. The one thing that I think holds back some individuals from accepting this is that it is clear that some people remit spontaneously. They walk away. They walk away from drugs. It's a rite of passage during their youth. They could fulfill all the criteria for addiction, the most severe forms, and then at some point in their lives, without any treatment, without any intervention. But what we understand now is that there are a number of factors that make it easy for some people to walk away and not others. And one of them is obviously genetics. Another is psychiatric comorbidity. Another is not having psychosocial support within families. Another is having very poor employment records and employment capabilities. There are a number of factors that make it very difficult for people to recover, and those are psychosocial and biobehavioral as well.
That leads nicely into our next point, is that there has been some resistance regarding the brain disease model, and we just wanted to touch on a few and see how we could respond to that. Moving on with what Bertha said, John, how would you respond to, well, addiction is not a disease because some people can get better without treatment, even if they hit criteria, they don't without treatment anymore?
Yeah, there is some opposition to the word disease itself. Now, I think, as I alluded to earlier, I think there are synonyms that we could use that are equally, and we don't know, this is an empirical question, whether disease is better than illness, which is better than disorder. Now, here's one thought, that disease activates a schema, psychological schema, whereby people think about when you say the word disease, they think about infectious disease. Okay, so maybe there is a cognitive schema that's activated when we say the word disease that some people, rubs people up the wrong way. They think, well, it can't really be a disease because, you know, they're thinking infectious disease. So I think a synonym could be disorder or illness. And I think equally, I don't see a problem with using either of those, disorder or illness. We've opted for disorder in DSM-5, for example. But I think the point is more globally, is that we're shifting towards public health and clinical approaches as opposed to criminal justice. And I think that's the main issue. Now, in terms of disease and why people might oppose it, that's one reason. The other reason is that there is some indication from surveys that people, when they think about they think about a chronically relapsing brain disease, that people think that you can't recover from that you cannot recover. Now, we know most people recover from addiction. Most people get into remission, full sustained remission and recovery from addiction. It can take many years for that to happen, but most people do. So I think we ought to add, yes, because I think the intent of the relative emphasis on addressing addiction and naming it as a brain disease is to decrease stigma, as well as to accurately reflect what it is. But also, we need to say that most people actually recover from this and lead normal lives. They get on with their life, they go back to work, they're good fathers, parents, brothers, sisters. They get on, they're taxpayers, they contribute to the community, they increase productivity, they do all the things that regular people do, and they can get and stay in remission. So I think we need to add that when we talk about a disease of the brain, but it's a disease of the brain from which most people actually do recover.
Patty, it can increase stigma. The brain disease model can increase stigma. How do you think that the recovery community could respond to that?
Well, I think that the recovery community has stepped up to put a face and a voice on recovery to say, you know, we are the evidence that people can and do recover, and there's millions of Americans that have overcome problems with alcohol or drug use, and that there are many pathways to recovery. So it's not, so the stigma that may surround the word or the concept of disease is actually turned around by demonstrating that regardless of the path of recovery, people can, you know, actively overcome the challenges with addiction. I know that we've seen an incredible amount of work on, you know, from everyone from policymakers to, you know, the mayors of cities and talking about their own addiction and in their family or in their own lives. I think that this is, you know, there's a lot of work that still needs to be done to make sure that our policies reflect that people can and do recover, and when we reduce the barriers, that will really come a long way to helping people.
Indra, how do we respond to the criticism that it wasn't me, it was my disease, if we embrace a brain disease model of addiction?
Perfect question. It was not me, it was my illness. Who
Well,
says
it's my
that?
nucleus accumbens that did it.
Who says that? These are the people who are addicted to the substances. As Dr. Medras and John and Patty has been like consistently talking about what happens, especially with the brain, right? When they don't have the full understanding of the decision-making power, obviously they're going to say what they want to say. But we as treatment providers shouldn't be harping on that. We should meet the addicted person at the level where they are at, and then try to work with them. Wonderful, now that you accept that this is a disease which caused all these problems, let's work with your disease and meet them there and try to treat them.
Bertha, how can we respond to the criticism, addiction is a choice, it's not a disease? What would you say to that?
Well, you know, there's an old Chinese saying about it. First, a person takes a drink, then the person and the drink take each other, then the drink takes the person. and I think it's a very clever summary. The fact is that people start using substances with complete free will, and although youth do have social pressures to use, and if there isn't a pushback, they will use, and it's not necessarily fully free will. But eventually, there comes a point along the progression towards a severity that the use becomes very compulsive. and it is no longer free will amongst a certain vulnerable population. It still can be free will amongst many, but certainly not the majority of people who have progressed down a path of severity. So I think that's I think that's quite an obvious distinction between it's all your choice. It reaches a point where your judgment, your impulse control, your craving, all these things that are physiological. You can actually see a person crave by imaging their brain. You can see certain brain areas light up when you show them a drug paraphernalia or cocaine. When a person who's never had that experience has no reaction whatsoever.
So in conclusion, what do we want healthcare professionals to take away from this? We've talked about the advantages and the disadvantages to the brain disease model, and importantly, we did review the difference between substance use disorder and addiction. John, can you just tell us about the significance of that for the healthcare professionals again?
Well, I think, non-specialist providers obviously it would be well to get more education, or we need a better training system of our physicians in medical school and nurses and social workers and psychologists and all clinical providers to understand the nature of substance use disorders and substance-related conditions. That we have the broad spectrum of substance-related conditions, substance use disorder, anywhere from 2 to 11 symptoms. And we have a cluster of severity symptoms, 6 or more, that constitutes, most would argue, an addiction syndrome that has at its core impaired control over the behavior despite harmful consequences. And I think the spectrum of harms that can come as a result of substance involvement, alcohol or other drug involvement, in terms of intoxication-related harms, toxicity-related harms, and addiction. I think we tend to default to addiction as kind of being the encompassing term, but we need to think about addiction, which is the compulsive use despite harmful consequences, but also the lower levels of use which can still cause toxicity-related harm, liver disease, cancer, as well as intoxication-related harm, particularly for young people who can get intoxicated. They may never meet criteria for a substance use disorder or addiction, but they can still die from intoxicating-related, driving their car, falling down the stairs, etc. So addressing this, screening for it early in clinical settings, making sure we detect it using validated screening tools, having a conversation, beginning the conversation earlier, even though we may not see a dramatic change right off the bat, to begin to plant seeds and destabilize emerging addiction patterns also.
Indra, can addiction be treated successfully? And if so, what's going to work?
Yes, addiction can be treated successfully, and we do have the tools. Early intervention, as John just spoke about, SBIRT, which is the short, brief intervention and referring patients to treatment, is the first step. And then from then on, you're going to match them with the level of care by using ASM criteria, which has been very clearly spelled out for the providers out there. And then use contingency management, because the reward pathway, it's good to give reward. So using the voucher model, here is where I would say decriminalizing the charges that one kind of gathers while they are using in good standing, say being sober for a considerable amount of time. If we can take out those charges, they will be able to go back into the society and make a living. So that might be a good way to look at. So Dr. Medras, you can take that into consideration there. And so that'll be a good thing in works. And also use network therapy, which is again a problem with the HIPAA regulation. Most patients in the outpatient level of care, they come in and they say, I will not allow you to talk to friends or family. Sometimes it's the friends who are their support network. So we make it a point saying that then you don't belong to an outpatient level of care, then you need to go inpatient. That kind of makes them pull and brings few support network. And involve the family. Integrating family is a key for success. What I mean by that is really teaching family members how to deal with addiction, and also teach them what medication does for them, how long they need to be on a maintenance medication, and not to push them to come off of it prematurely. That leads to overdose and death. That's really sad to see. And I think we have every tool that's possible on the table, and we need to use that. Not only treat the patient, as providers, we should use the toolbox appropriately.
And Patty, can you speak to the role of recovery support services regarding treatment?
Absolutely. People can and do recover from addiction, and recovery support services are critical to help them maintain long-term recovery. The most important thing to remember is that treatment is effective, and it is in many cases time limited or short term, and that recovery support services can help people maintain their recovery for a lifetime. So including peer recovery support services, recovery housing, recovery community centers, recovery coaching, lots of, and across the lifespan as well, in recovery high schools, collegiate recovery programs, and across the nation we're seeing a lot of these evolve, and the field or the medical community should be more aware of those types of recovery supports that are really helpful to people as they engage in treatment, and those other support services around in the community.
So before we take a question from our online guests, I'd just like to ask any of you if there's anything else that you want to say to the healthcare professionals on how they can best support their patients with substance use disorder.
Definitely reduce the stigma among the providers, and not think about most of the providers, most therapists out there are recovered from substance abuse, so they should be more than willing to embrace these treatment modalities that we have in place.
I would like to add, and this has been my mantra for more than 10 years, that every physician should be screening their patient for substance use and substance use disorders. Without universal screening, we are not going to identify people at risk for progressing into a disease. And this is probably one of the most important forms of prevention that can be done in the healthcare system.
Okay. Let's take a question from an online guest with our last couple of minutes that we have here. Does relapse mean treatment has failed? I'll let anybody jump in on that.
It's an easy one. As it was said more than 100 years ago, it's very easy to quit smoking. I've quit 5 times, and that's the
20 times, I think he said. But
did he say 20, not 5?
Yeah. Mark Twain, yeah.
Well, it's clear that relapse is part of the process of recovery, and not necessarily in all people. Some people recover after 1 try. Other people require a number of tries. The most important thing is not to give up on the individual if they do relapse, because it is very, very difficult. Imagine having a disease in which you're willing to risk dying from an overdose. It is so counterintuitive to understand that a person is willing to swallow something that could kill them. And that is a reflection of how powerful the impulses are to use. And it's also a reflection of how difficult and how many challenges they have to surmount the craving. Therefore, one should not give up.
In fact, when we look at retrospective and prospective studies looking at the clinical cause, we know that roughly it takes 4 to 5 treatments and maybe several years before people achieve that 1 year of full sustained remission. So as Bertha says, you know, it's learning how to adapt to sobriety. You know, how do you adapt to recovery? And it's the adaptation to recovery, which is learning a complex set of skills while you're experiencing a great deal of stress. This is very difficult for people. And so it's also a learning process of what people find that they need to do to get and stay in recovery.
How long does it take for the brain to recover from addiction?
Well, I think it's one of the most difficult questions that we can try to address, because there are very few longitudinal studies that have been done on individuals who have an addictive state with regard to markers of addiction. Therefore, we don't have the answer. What we can say empirically is that a person can recover. Whether or not all the brain changes are reversed, we simply do not know. In humans, we can have a certain measure of it in animals and in preclinical studies. But I think one of the problems is that we don't even have a full array of changes with regard to what drugs do to the brain in order to know what to look for across the entire spectrum of neuroadaptation.
And to add to that, integrating dual process modalities, the models of explicit and implicit cognitive processes that takes place in the brain. What I mean by that, the explicit one is like looking cool by using drugs and or saying that I'm relieving tension by using drugs. That's then explicit cognitive processes. And the implicit ones are the cues from the person, place, and and things. Just by walking through the street where the liquor store from which the person buys liquor, that can become a cue. So as a treater, the therapist, using this dual process models can really make the difference.
Okay, so that's all the time that we have for today. A big thank you to our wonderful panelists, and a big thank you to all of our viewers who tuned in today as we discussed addiction as a brain disease. Please visit SAMHSA website for more information on this webcast, including a taped version of the broadcast and resources we did discuss today. Join us again for our next webcast in the series on Tuesday, May 22nd at 2 p.m. Eastern Standard Time, when we'll talk about reducing discriminatory practices in clinical settings. We look forward to seeing you then.